Bharti ma'am, please go ahead. Bharti ma'am.
So it is just 4 p.m. So good evening, everyone. And we are here to welcome all of you at the FOGSI ICOG webinar on safe abortion and contraception. And today's theme is that pregnancy by choice, not by chance. And as today we welcomes all our FOGSI and ICOG office bearers, as well as we have today very eminent speakers on very important topic, that is Dr. Sheila Mane madam, Dr. Sarita Bhale Rao madam, as well as Dr. Vidya Topi. The topics are very interesting. That is contraception on extremes of age, that is in adolescent as well as in after 40. And then I always found that being a working in last few years in the MTP and contraception, that MVA is always remain a gold standard for doing safe abortion. So that a talk will be delivered by Dr. Vidya Topi in detail about the procedures and advantage of MVA. And then we will have very good interactive panel discussion on very important clinical tips how to make contraception more effective. So we first of all, please share the CV of our FOGSI president, Dr. Sunita Tenduvadkar madam. We all know that she is the president, as a president FOGSI, organizing such a academic and having so much of innovative ideas that is benefiting all our women health, as well as they are giving direction to all of us obstetricians and gynecologists. Thank you, Dr. Sunita madam, for giving this opportunity. And then we have, please next TV, please. We have a ICOG chairperson, Dr. Parag Viniwale. I just see whether he has joined. Um I'm not able
Sir,
to see
yet
him.
to join.
So we welcome Dr. Parag Viniwale. He is always open-minded and hearted to give opportunities and freedom to organize important programs, and especially then very important subject, that is safe abortion and contraception. Thank you, Dr. Parag sir. Then we have next CV, please. Then we have our at present ICOG, our FOGSI secretary, Dr. Suvarna Khadekar madam, and then ICOG chairperson-elect, we have Dr. Sheila Mane, we have Dr. Ashok Kumar sir, and we have Dr. ICOG Secretary, Dr. Sarita Bhale Rao madam. She will deliver not only talk, and she will give her blessings also. And then today's convener, myself, Professor Dr. Bharti Maheshwari. I'm a professor and head of department OPGY. And then we have important chairpersons with us. That is that I will yes introduce Dr. Shobha Gude. She is the chairperson, past Family Welfare Committee chairperson. Then we have in the first session the chairperson. Next slide, please. Dr. Anjana Khanna. She was a past FOGSI vice president as well as governing council member ICOG. Next, please. Then we have a Dr. Saroj Singh madam. She is a professor and head of the department of Gynae UPCOG president as well as governing council members nowadays. And Dr. Kanchan Sharma, she is a professor, Sri Thankar Medical College, Muradabad, and GCM elect. So with all these eminent faculties and chairperson of the first session, now I invite our first speaker. She is Dr. Sheila Mani madam, that she is the ICOG chairperson elect, Vice President FOGSI 2014, Chairperson Safe Motherhood Committee, but and as well as President BSOG, as well as President BMS Bangalore, National Facilitator Adolescent Health, and we all know
Yes,
her as a PPR lady.
Sheila Mani.
Yes, madam.
Yeah,
So
yeah.
first I request Dr. Sarita Bhale Rao to say a few words of blessings as the ICOG secretary, and then invite us chairpersons, if they are here, to say a few words and invite our speaker.
Thank you, Dr. Bharti. And I really congratulate you on doing this FOGSI ICOG webinar on safe abortion and contraception. And you have really chosen a very nice topics. These are all topics of great clinical importance, and they will be of interest to all our practicing gynecologists. So I'm sure it's going to be a wonderful evening, and I'm really very happy to see Madam is here, Dr. Sheila Mane, Dr. Saroj Singh is there, Dr. Ambuja, Dr. Manish Pandya, Dr. Vidya Thobi. It's wonderful to see everybody here, and it's going to be a great evening. We are
Thank you.
now all gearing up to the AICOG 2026, and this year we'll be awarding all close to 200 fellowships. But for all people who've missed this chance, please do register online, and you will receive your fellowship in Bangalore in August 2026. With that, back to you, Dr. Bharti. You can carry on.
Thank you.
Thank you.
Thank you, Dr. Sarita Bhalerao, madam. Thank you, in fact, that you have given me opportunity to organize this and given all support, and even you have agreed to be a speaker. And then I can see a chairperson, Dr. Shobha Gudi. Are you here? I'm not able to see, madam. Then Dr. Saroj Singh is here. Dr. Saroj, madam, please say a few words about the
Yes.
topic. That is what Dr. Sheila Mane, madam, is going to deliver, contraception in adolescent.
Okay. Okay. Thank you, Bharti. It's a great privilege for me to be here in the ICOG webinar for the first time. Being ICOG Governing Council member from the January, I'll be the regular attendee of all this. It's a great pleasure to be here. I congratulate Bharti for selecting particular this subject, and especially the contraception in adolescent, which Dr. Sheila Mane is going to speak. It's very important subject because we are seeing that in last few years the adolescents are at very young age they are becoming sexually active, and many times they are coming to us for medical abortions and so many problems associated with incomplete abortion or problems of abortion. So it is very essential that they should know about contraception, and in addition to that they should know about the sexual knowledge that also they should have, and prevention of STD also they should have, and all that. Who else can better tell us than Dr. Sheila Mane? It's a great honor for me to invite Dr. Sheila Mane, who is ICOG chairperson elect, and a long list of feathers in her cap.
And a close friend. And all of us.
And a very close friend. And it was a great honor for me to welcome her when she came to Agra in our conference. And we know her as PPH Queen, managing all the cases. It's for you.
Thank you.
Please.
I welcome Dr. Manish Pandya. Dr. Manish, very nice to see you in this program. And God is really great. So very nice to have you here. I could see Manish joined. I hope he's there. So welcome back, Dr. Manish Pandya. And very, very happy to see you here. So without any wasting time, I will start my talk. Of course, I mean, with a very short notice, I started. So I told Bharti that you have to help me out because they are day in and out, they are into this. So I said that it is very important. So anyway, I got it from her. So as everybody knows the importance of this, am I audible?
Yes, ma'am. Very much.
Yes,
Yes,
you
ma'am.
are.
So
Audible,
contraception
visible,
for
very nice.
adolescent. So nice concept, Kishore Kishori Maitri Swastha Seva. I know all those things are there, but how much is our reach? That is the thing which will make us think, after this presentation. And when I was going through also, I felt that whatever we are doing is not enough. Okay, we have all these definitions, we have all these number, but still at the ground level, there is not much change. So WHO defines as the age between 10 to 19. And we know that it is a time of tremendous physical, cognitive, social change. And when many people
You have to share your slides.
Sorry. Let me go back. Oh, it did not. अरे क्या करायचं आता? What to do? Oh, before sharing only I started, I think.
Open your presentation and just share. Click on share button.
नहीं, मैं अभी वो कर रही हूँ, लेकिन मुझे ना अभी वहां पे कुछ भी मुझे आगे आ रहा नहीं कि जहाँ पे मैं क्लिक करूँ. Something like to go back or something like that. I'm not
No,
getting
move your
anything.
cursor, it will go. You move your cursor.
हाँ, एक मिनट.
Yeah.
Oh, yeah. I forgot only. Okay.
जी.
Fine. Is it seen now?
Yes. No,
Yes,
it's
ma'am.
yes.
Yeah. It is seen
That's
now.
right.
You have to
Yes.
make full screen.
Ma'am, is it full screen, ma'am?
Yeah. It is full screen. You
Full
can change your slides. Yeah.
But the slides are not moving.
Ma'am, click on the
Yeah,
slide.
yeah, it is
Hmm.
moving. So all of us, we know about the definition, the age group between 10 to 19. And this is a time where there is a lot of tremendous physical, cognitive, and social change. And many people get into, initiate sexual activity. So this phase of life also presents with fatal and life-threatening health risk due to the risky behaviors. And nearly 35% of global burden of disease has its roots in adolescence. So 35% is, I think, quite high. And we know that engagement in sexual behavior is due to the ignorance of most of the adolescents. Just a minute. Okay, fine. And it's more common in low and middle income countries, and they become pregnant, and that is about almost 12 million give birth. So out of 21 million girls, 12 million give birth. That means they are sexually active. And the global adolescent birth rate for girls aged from 15 to 19 has fallen from 64.5 births per 1,000 women to 41.3 births per 1,000 women in 23. But they account for 11% of all births worldwide, and 90% of adolescent births occur in low and middle income countries. Now, according to NFHS 5, about 6.8% of women aged 15 to 19 were either pregnant or had already given birth. Higher incidence in rural areas than in urban, and one estimate almost gave 9.2% in rural versus 5% in urban. And some states show much higher rates. For example, Tripura, 22%, West Bengal, 60%, Bihar, 11% among adolescent girls in 15 to 19 age bracket. In spite of these states having early marriages, I mean, there the girls, they are getting married even before the age of 18 years. And the likelihood of teenage childbearing is strongly associated with early marriage. That's what I told. Low education, poor households, and certain social groups. And most of the time, these children are dropouts from school. Now, improving adolescence access to and use of contraception. Yes, we have such a big list. Okay. All of us, we know that. And that is, there are barriers. What are the barriers now? Provider attitude and social norm. First of all, we do not have adolescent friendly or youth friendly services. Now, as I'm associated with Family Planning Association of India, we call it as youth friendly because we extend it up to the age of 25. But you know how many places are there? I know Government of India have had this initiative, and we'll still have to maintain the record of adolescents coming for our OPD. But we do not have separate clinics, and we are not friendly. So if we have still not taken the initiative, I can ask the feedback from others. I don't think we can reach our goal. So yes, definitely the provider attitude, social norm, because nobody is being trained, lack of confidentiality, limited method choice, cost of accessing the services also important, and limited client knowledge. Now, high impact practice enhancement is what? Incorporate all these adolescent friendly service delivery elements into existing contraceptive and health services. Service delivery charges, non-judgmental. That is, we have to have a gather approach. Okay. Audio and visual privacy, wide range of contraceptive methods, free or subsidized services, and community. Now, what happens? Our OPD is 95. Can we expect them to come to us during that hour? No. They are going to school or they are going to colleges. So that is not possible. I remember in Bangalore, the Family Planning Association of India, we have a clinic which runs in the evening. So, and it has to be a different timing because they need privacy, their confidentiality. So they do not want to walk in when you have all sorts of patients there, because then there is no confidentiality. Benefits improved, if we have, then improved knowledge of SRH and contraceptive services, better attitudes about contraception, greater access to and demand for contraceptive services. Outcomes, increase in satisfied contraceptive use among adolescents and reduction in unintended adolescent pregnancy. So how it should be the adolescent friendly health clinic? It should be there at district level, and it is there in the government guideline, and it should be called as AHRC. They, apart from providing the full complement of services envisioned on FHC, will also act as a resource center for capacity building of healthcare providers and repository for information, education, communication material on adolescent health, such as posters, banners, pamphlets, and AV material. Now, counselors play a crucial role in popularization of adolescents-friendly health clinics. So the best problem is we do not have. Okay. Now we have started other clinics. Okay. Like for the women now we have. But there the counselor is sitting. But as such, we do not have a pure adolescent health clinic where we have a privacy. Now, local education agency, lead champion, all those things are here. So sexual health education, sexual health services, and safe and supportive environment. And if we look at the outcomes, what we have to look at in them is sexual behavior. They can contact sexually transmitted diseases, even HIV, unintended pregnancy, substance misuse, mental health and suicide, also common, violence and victimization. So these clinics can inform, educate, and counsel the clients on adolescent health issue and refer clients to the facility or other service delivery points such as integrated counseling testing center, de-addiction center, and non-communicable diseases clinics. I don't know. We come from different cities. How many of you are aware of Family Planning Association of India clinics? Now, factors that increase the risk of early sexual activity is need not be low socioeconomic, because we are in Bangalore urban, we know. Living in a single parent home, yes, possibility. Engaging in risk-taking behavior, like if they have a drug abuse, and also the peer pressure. Having sexually active peers, in some cases early or rapid pubertal development, which is happening now. Now, why they need contraception? Because they are almost 22% of total population. And I think today we are the highest or second highest of adolescent population in the world. 50% girls get married before 18 years, contribute to 19% of TFR. Now, this 50% girls getting married before 18 years is not there in all the states. We know that the awareness is there, but still it is happening. But there are certain states where they have still not abolished child marriages. 50% risk of course, morbidity, mortality. Only 5% use modern contraceptives. Premarital sexual relationships have increased. Trafficking and prostitution is another problem. And all the STDs are increased among the adolescents. And 40% youth start the drugs and substance abuse between 12 to 18 years. Nearly 15% of adolescents are working. See, today we are talking that our youngsters, so this should have been our thought when we knew that our adolescent population. And why I'm talking that? Because I have had an opportunity by getting trained with the WHO module by Dr. Durusha, where we had an adolescent health module, and it was a 3 days program. Myself, Dr. Parag, and all of us are trained, and we used to train people. So only 1% adolescents receive quality counseling, health and medical services, and they are more prone to HIV infection in comparison to other age groups. Substance abuse, lifestyle disorders create significant percentage of burden on disease on health system, and they contribute significantly to IMR, MMR, and TFR, total fertility rate. And all these factors increase the outcomes are not good. So prevention of adolescent health issues is how maintaining proper genital hygiene as well as menstrual hygiene. I think FOGSI we are doing, public awareness community is doing, practicing responsible and safe sexual relationships, avoid unprotected sexual contact, as well as relationship with multiple partners, adoption of all preventive and promotive measures by both partners, and improve the delivery of adolescent-friendly health information. Now here, both the partners are young, Sometimes it happens, yes, another person may be more than 18 years, but how many people, those who are even youth, know about it and they approach. Now, when we look at this list, I know this list is there. There is a cafeteria approach. Unless and until there is a privacy, I don't think we can talk about it. Okay. But still, for the completion per se, long-acting reversible contraceptives, this is the list. Now, what is there for the adolescents if we look into that? Okay. We have to make them aware about emergency contraception now, because it is not that it is happening on a regular basis in them. And injectables, if we talk, we do not advocate if the girl is less than 16 years, because still the bone formation has not happened. So we don't want to give them, because that will cause resorption. Okay. So we have either a mechanical, like that is barrier methods. Okay. That is male condoms. Now diaphragms and female condoms are not at all easily available. Okay. To talk to them about withdrawal, we will have to really sit and talk to them. Yes, they can use oral contraceptive pills, okay, and they can also use the barrier methods, as well as I think progesterone only pill also can be used. Now, what are the barriers, laws and policies? And all of us, we know the law in our country. Laws often police adolescent sexuality, and policies can prevent provision to these unmarried adolescents. Gender and social norms, there is a stigma, okay, unmarried adolescent sexuality. So legitimize, conceive, coercive sex, pressurized in them, married girls to prove their fertility, and limit the girls' mobility and agency can hinder adolescents from seeking services. Misconceptions and lack of knowledge is always there. Financial barriers, yes, they are not self-sufficient or empowered. So naturally, for them, it is difficult to go and ask for something. Lack of privacy and confidentiality, I discussed, and provider bias, because if we are not trained, definitely what happens is, if she goes to somebody, can scold her, why do you need it like that? So we have to change our attitude. Counseling context is very important, social and cultural norms and gender roles. So counseling process, we have to assess the situation, define problems, needs and information gaps, generate alternatives, prioritize solutions, develop a plan, review and evaluate. That will happen only if we have a special clinic. So the guiding principles are encouraging interaction, build on skills and knowledge, shared problem solving and tailoring to specific needs. So the skills, it is a two-way communication, forming an alliance, active listening, open questioning, providing information and facilitation. So the counseling steps are friendly approach, gather, that's what I told you. So you have to greet them. So introduce yourself, ensure privacy, build trust and reduce. Most of the time now the girls come, no? So most of the time what I do, I ask the mother to wait outside, because so many times the girl will not open up. Assess needs, that is age, sexual activity, history, menstrual history, knowledge of contraception, really if they have, what are the fears and misconception. And if they are married, desire for pregnancy prevention, whether it is there, and also tell them about STI protection. Provide information, discuss all available methods, temporary spacing, emergency contraception. And you have to tell them the advantages, disadvantages, and we know the myths. Even the married people, those who are adults, they themselves also hesitate in taking, and soon after marriage, they will come for MTP. So we can emphasize condom use for STI prevention. We can assist them in method selection. We have to support them. Now there comes, the choices are based on convenience, medical eligibility, partner support and reversibility. Correct use, you have to show them proper condom use or pill schedule if applicable. Address the myths and misconceptions, like they think that if they use pills, they will have infertility and like that. And they think withdrawal is safe. Ensure dual protection also, because if you are telling them we know the failure rate, okay, and then plan for follow-up, they should return, they should come back to you, not that once you have given, and that is if we have developed confidence by counseling, they will definitely come back. So the key messages are, contraception is safe and reversible. Condom protects from both pregnancy and sexually transmitted infections. Emergency contraception is for backup only, because otherwise people keep on taking. Open communication with partner is important, and seek medical help for side effects or method failure. So this is the thing which you will have to talk: confidentiality, managing parental absence, because You will have to tell them because they don't come with parents. Non-contraceptive benefits also if they're taking the pills. Remove their myths about the safety and social determinants also because they are very young, they don't know. We can tell them, okay, about relationships and family dynamics. Contraindications we'll have to take into consideration the history like smoking, obesity, and for adherence we will have to counsel them more. And sexual health counseling is again very, very important when the young people are coming to us. And we have to avoid the medical barriers to contraceptive provision. For example, delaying initiation until next period or need for pelvic exam, STI screening prior to IUD insertion like that. So what are the consequences now compared to the pregnancies of women in their 20s? Adolescent pregnancy may be attended by increased levels of mortality, morbidity we discussed. And 1 in every 20 adolescents and young people, they contact STI each year. 1 in 20, okay? And young people may not seek help for STI because they do not realize they have an infection. They're embarrassed. They don't know where to go, okay? And no access. Late treated or untreated can potentially hinder the adolescent's long-term health and fertility. Unsafe abortions and legal abortion, we know, rarely available and accessible outside the developed world. Unsafe abortion, which is the cause of 13% of global maternal mortality, is common in places where abortion is legal. And I think all of us are suffering with this, I think. Tends to be more because most of them, they'll land up with taking tablets across the counter. Social and personal consequences, there is an effect on personal, social, and educational life. They are often irreversible. Many become social outcasts. Sometimes young women are forced to give up school because of a fear that they will be a bad influence on other girls. And they may limit or preclude social and educational employment development and the ability to achieve full status in society. So coming to this, I think these slides are very important because, when we are talking about contraception, the government policy, we know, medical legal aspects. So under the Protection Act of Children from Sexual Offences, that is FOGSO Act 212, and sexual activity with a person below 18 years of age is considered statutory rape even if it is consensual. Therefore, all pregnancies in girls below 18 years must be legally reported as a case of sexual offense that all of us we know. And mandatory reporting. So under Section 19 of FOGSO Act, any healthcare provider who comes across a pregnant minor must report the case to the police or child welfare committee. Okay. And failure to report is a punishable offense, we know. So the consent now for medical examination. So consent for examination or MTP, minor, yes, you will need a guardian. If above 18, she can give her own consent. Confidentiality need to be maintained. And when confidentiality is respected under POCSO reporting, obligation overrides the confidentiality. Medical termination of pregnancy act, it can be legally terminated up to 20 weeks with the opinion of one medical practitioner, 20 to 24 with opinion of two. In minors, guardian is must and they must be reported to authorities, which we are doing. Preservation of confidence when examining an adolescent must collect samples for DNA if rape is suspected, document injury statements and gestational age, and maintain proper chain of custody for medical legal evidence. Confidentiality, detailed accurate medical records, age, group, consent, clinical finding, use of separate medical legal register for adolescent pregnancy cases is recommended. Now, what happens recently we face this problem. There is only one medical legal register. It shuttles between casualty and OBG department. So now we have started keeping separate. Counseling and support, offer psychological support, counseling, and referral to child welfare committee or social worker. Focus on rehabilitation, education, and prevention of further abuse. So I will not go into the details. All of us, we know these are the infections they can catch. Okay. Gonorrhea, 2 to 5 days. Syphilis, 10 to 19 days. And chlamydia, again, 2 to 3 weeks up to 6 weeks. And lymphogranuloma variola. And these are the latest updates. I think in our OPDs, we do have these NACO kit 8 for anorectal discharge syndrome and all that, and depending on the anorectal discharge is in the new one. And we have, and according to these symptoms, we prescribe. Some of the delegates can take the picture of this. We have it regularly. Contraception in adolescence, coming to that now. Now, comparison of some features of selected hormonal contraceptives there, and these are all the pills. Now, If she is coming to us, yes, we will prefer a low dose only. Okay, because the side effects will be less and the adverse events also will be less. Okay, and there is a increased likelihood and incidence of unexpected breakthrough bleeding and spotting with low dose, but increases possibility of decreased efficacy with missed pills. But first we start and then we can go to low dose. Okay, now in government setup we have only 30 microgram. Coming to drospirenone, most of the time now we know it similar like a natural progesterone. It will also help if they have PCO, hirsutism and acne. Extended cycle, that is giving them continuously for 84 days followed by a 7-day inactive tablet interval. And when adults are also not taking, even the career-oriented girls, when they are traveling, they only prefer to take it like that. Progesterone only pill, oral option in patients unable to take estrogen-containing compounds may be taken. I mean, breastfeeding, we know it is ideal. And depot injection, I told you, below 16, we will not advocate. Now, implant, nobody will agree. Transdermal patch is not easily available. All these things are not. And IUD. Now, IUD, again, if we are advising, we know that we need a very small IUD and you will have to do so much of counseling and nobody will. So according to me, practically the options left are, you have to tell them about the barrier methods because you don't know about their partner. They can use the oral contraceptive pills, the low dose, and another thing is the emergency. So these are all, we know all, and it is good to use the MEC wheel for contraceptive use in India. We have that, and even if they have any other problems also, we can use accordingly. There are indications. Now, I would like to talk about the challenges. There is limited understanding of reproductive health and contraception, and myths we told. And they think first sex can't lead to pregnancy, and poor sex education in schools and families, which I think we will have to take it more seriously. And cultural taboo, stigma, and judgment associated with if they come to us, and fear of disclosure to parents and community. Limited access, and there is a cost and availability issues are important, privacy and confidentiality concern, and partner related factors. That is unequal power dynamics, especially for adolescent girls, and male partner may refuse to use, and peer pressure and coercion. Irregular sexual activity makes method planning difficult because they may not have regularly. So higher risk of contraceptive failure, psychological and emotional factors because impulsivity, experimentation, and risk-taking behavior. And there is a fear of all that side effects or infertility and lack of confidence in negotiating the contraceptive use. And provider, we discussed. So it is an unmet need. So many sexually active adolescents wish to avoid pregnancy but do not use due to above barriers, and consequences we know. Unintended pregnancy, unsafe abortions, they catch all the STDs, school dropouts, psychosocial stress, and socioeconomic burden. So what are the strategies now? Yes, you have to have a comprehensive sexuality education, adolescent-friendly services, confidential counseling, easy access, empowerment and communication, and involvement of parents, teachers, and peers. Coming to medico-legal, now consent, sexual consent. Again, under FOGSI, it defines a child as anyone below 18 years. So any sexual activity with a person under age that we discussed, legal age we know below 18 is not allowed, above 18 for boys above 21. And medical consent. Under Indian law, a person aged more than 18 years can give valid consent for any medical or surgical, but minors you need guardians. For contraceptive services and confidentiality. They may seek contraception confidentially, but legally they are minors. So doctor face a balance between confidentiality and adolescent autonomy and legal obligations under FOGSI. So comprehensive counseling must include explanation of available methods. Yes. Risk benefits, failure rate, side effects, dual protection, importance of regular follow-up, and if the adolescence is under 18, written consent from a parent, guardian should ideally be obtained before invasive or prescription-based method like IUDs or hormonal contraception. So here comes the hitch. As so far we are talking, we have to maintain the confidentiality and all that. But now under law, if they are below 18, then we need somebody that too, if we are going to give her hormonal or we are asking her to use the IUCD.
Sorry to interrupt you, ma'am. Ma'am, your time is up.
Yeah, I am done. may be given to prevent pregnancy, legally permissible, but prescribing to girl below 18 may trigger mandatory reporting under FOGSI. So since it indicates a sexual activity with a minor. So provider responsibilities, this is important. Maintain detailed documentation of counseling and consent. Follow confidentiality but comply with mandatory reporting laws. Provide non-discriminatory adolescent-friendly care. Avoid moral judgment or coercion in decision-making. And provide referral for psychological or social support if needed. So these are the things. So all of us, we know about the MTP Act and all that. I think that is not required here. We are talking about adolescent contraception. So there are two contradictory laws brought by government. One is, even if it is consensual sex, it is punishable. Another is they want us to promote and talk about adolescent contraception. They were on one side, they say maintain, thank you, I have finished. They say maintain confidentiality. Other side, we talk about it, that if we don't talk about it, we will have more teenage pregnancy. So I think the FOGSI has to really take an initiative and talk to government to see to it that either the age is changed, because it was earlier, I think 16, or something need to be done about it. Thank you.
Thank you so much, Dr. Sheila, for clearly describing what is the need for adolescent contraception, its social issues, medical, legal issues, and clearly telling us that it's mainly the barrier methods or it is the hormonal contraception, maybe that they are using it as extended regime or preferably the low dose pills, which you have mentioned it very nicely. So it's an excellent presentation by you. One thing I want to say that in UP, as NHM is providing MCH blocks in different districts and medical colleges, they are giving ARS clinic.
Yeah, they have.
Which is the adolescent. And that is practically, it is made, although there is no counselor, nothing practically, it is not being used, but ARS clinics they have established.
Then I think we have to take the initiative. If we have a MCH block now everywhere, no, under NHM, the MCH block is coming, so we need a counselor. If we don't have a counselor, then
it's the PGs they are sitting whatever this being
but
done.
PGs only are not trained, no.
But practically they have made it essential that there should be one ARS clinic in every center that they have made.
Let us see what we can do. I can take I mean, you are there, all of you are there. Let us see what we can do through ICOG. Thank you, Dr. Maheshwari, for the invitation. Thank you for the PPT. And I would just like to say, find out how many of you are associated with Family Planning Association of India. You can put it in the chat box, because in FPAI, we have youth-friendly services. We have clinics, okay?
Yes.
So,
Yes.
if we at least, I mean, collaborate with them, with our local gynae societies, we can really do something, okay? And I think that is the way right now, even if we have ARSH clinics, because they have counselors. FPAI have counselors, okay? Thank you.
Thank you very much, madam. And am I audible?
Yes.
Am I audible? Yes.
Yes,
So
we
thank you
can
very
hear
much.
you.
Okay. So a very beautiful talk, Sheila madam, and thank you for sparing time and agreeing at a very short term. So thank you very much. And we will have a quiz also in the last of this sessions. After around 5:30 p.m. we will share the link. So all participants, please participate. You all will get e-certificate. So now we are coming to Dr. Sarita Bhalerao. She is going to speak next topic that is also very important and most of us want to hear, and that is on the contraception over 40. And we all know Dr. Sarita Bhalerao. I know her as a very pleasant, very humble, very sweet person, and she is a consultant obstetrician and gynecologist at Beach Candy Hospital, Mumbai, as well as nowadays secretary ICOG, immediate past chair AICC ICOG West Room, and has lots of academic credit in her. So now over to Dr. Sarita Bhalerao, and I think my chairperson, Dr. Shobha, and Dr. Other chairperson, as they will join, they will conclude the session.
Thank you very much, Dr. Bharti, for that kind introduction and also for inviting me here. Am I audible?
Yes,
Can
ma'am.
you hear me?
Yes, ma'am.
Yes,
You can. Yeah, thank you very much for inviting me. And I really take this opportunity to congratulate you for all the work you've done in this area of MTP and of family planning. And I have your little handbook of MTP with me here in the clinic, and I refer to it very frequently whenever I have a problem. So my topic for today is contraception in women above 40 years, which I think is also a very interesting and an important topic for all of us in clinical practice. So you'll ask, fertility after 40, is there a need for contraception? And our first concept is that yes, we know that there's a reduced fertility after 40, and the term is used is called fecundity rate, where the fecundity rate is the potential for fertilization that goes down, and it is only 0.06 for women above 40. But should they conceive, it can be very serious because maternal and perinatal morbidity in pregnancy after 40 is considerable. So it is not, so we have to encourage contraception, and safe and effective contraception is really the need of the hour. Remember that women above 40 have very special needs. One is that they may have other medical comorbidities, and they also may be suffering from perimenopausal symptoms. And so we have to address all this in our healthcare. So WHO medical eligibility criteria are really fantastic for selection of contraceptives. And I just want to revise this once. Category 1 is a condition where there is no restriction, you can use the method. Category 2 is when advantages outweigh the risks and generally they can be used. Category 3 is where the theoretical or proven risks outweigh the advantages, and so preferably do not use the method. And category 4 is a definite no-no, that the condition represents an unacceptable health risk if the contraceptive method is used. So I think that we have very clear guidelines now coming from the WHO, and for each morbidity, we know what we can use and what we can't use. I thought this was a very, very interesting slide which shows when to stop a contraceptive in a woman. And let's first look at the category when they are on combined hormonal contraceptives or they are on Depo-Provera, for example. Here, there is no sign or no indication of menopause. So what they say is that from 41 to 49 years old, you should continue if they are satisfied with the method and there are no contraindications. And when they are over 50, stop and then switch the method to some other method depending on their need. If they're using condoms, diaphragms, copper IUD or fertility awareness, then they have menses. So 2 years, if they're between 41 to 49, stop 2 years after the last menses. And if they're above 50, stop 1 year after the last menses or at the age of 55. And if they have a POP or an implant or a 11H gestrel IUS as a contraceptive, they can continue if suitable or stop 2 years after two FSH levels are more than 30 units per liter, at least 6 weeks apart. And if they're over 50, then stop 1 year after one FSH level is more than 30 or at the age of 55 years, which means that there's still a chance of pregnancy for quite a long time, and we do need to continue. So I thought these are helpful guidelines that we can use in practice. So first, I'm going to discuss with you the short-acting reversible contraceptives, which are very familiar to all of us. Now, the barrier contraceptive, the condom in this age group is a very good because it has no side effects. It's easy to use. It's very safe. But remember, it is even more reliable at this age rather than younger women because fertility is declining. But the problem is that the user failure rate is higher than other methods. Even with perfect use, condom may leak or break, and the failure rate is 2%. With the real world use, the failure rate is as high as 13%, which is really quite a high failure rate. So they have to use this with a backup method as an emergency contraceptive pill or switch to some other method. What about the combined oral contraceptive pill? And most guidelines will say yes, that the low dose oral contraceptive pill you can use safely up to the age of menopause unless they are at high risk. And the benefit of using the combined oral contraceptive pill in this age group above 40 is that it will take care of mild menopausal symptoms in women who have low estrogen. It will improve their bone densitometry. But remember that there are certain risks, and the venous thromboembolism risk does increase sharply after the age of 40. And I just put these figures to show you that it is 8.7 per 10,000 when they are 30 to 34 years. It goes up to 20 per 10,000 when they are 45 to 49 years. So for these women, it is recommended to use a lower estrogen, avoid levonorgestrel, But remember, consider the risks of pregnancy versus these risks, because even if they get pregnant, the risk of pregnancy after 40 and the risk of venous thromboembolism in pregnancy is significant. So they need to use reliable contraception, and the risk using a contraceptive pill is still less than the risk of something in pregnancy. And the pill, of course, we know is a fantastic molecule for many, many things, but few risks are there. The overall risk of stroke is increased 2.2 times. Myocardial infarct is also increased. And combined oral contraceptive pills are now available containing estradiol, which is safer than ethinyl estradiol. And short hormone-free intervals give better menstrual cycle control. And this E2 estradiol pill is similar to menopausal hormone therapy and therefore shares some benefits with a lower cardiovascular risk. So I thought I'll spend a little time and discuss this. This is the quadriphasic pill, which is now available. It contains estradiol, valerate, and dinogest. It contains 28 tablets, 26 hormone-containing tablets with 2 placebo tablets. And you can see that the concentrations are in 4 different ways. And they have to start from the day 1 of the cycle, take the pill every day without a break, because there is a 2-day placebo, no break. But the advantage of this one is because it is estradiol, the DVT risk is less, the high HDL level increases, which is protective. The duration and the intensity of a withdrawal bleeding is less, which is helpful in patients who have heavy menstrual bleeding and menorrhagia. Some adverse effects may be there of breast pain, headache, acne, alopecia, migraine, and weight gain, which patients should be aware of. But overall, the satisfaction rate is as high as 80%. And though this is an expensive option, it is a very good option for women who have mild menopausal symptoms, also require contraception, and those who have heavy menstrual bleeding. This is a very good option. They have to follow it very carefully. That is the difficult part. But if you explain it to them, they will be able to cover it. Then we come to the progesterone only pill, and we have now the 4 milligram drospirenone available, which suppresses ovulation and thickens cervical mucus. It is a 24-day pill followed by a 4-day hormone-free interval. Drospirenone has strong anti-mineralocorticoid and anti-androgenic activities. So it lowers BP, reduces bloating, doesn't cause weight gain, which is very helpful. There's a less of a cardiovascular risk because there's no estrogen in it, and less unscheduled bleeding as compared to the other progesterone only pills. But all progesterone only methods will have some risk of unscheduled bleeding. So when we look at the progesterone only pill, who would you give it to? Those who have medical contraindications for estrogen containing contraceptives, and WHO criteria say 1 and 2 for women over 35 who smoke because estrogen is contraindicated, or those who have migraine with aura, or those who have had venous or arterial thrombosis, who are hypertensive, who have diabetes with vascular disease or cardiovascular disease. So these are the patients where estrogen is not to be given and the progesterone only pill should be given. But who should not use? Those who have liver tumors, cirrhosis, breast cancer, anybody who's had malabsorption or a bariatric surgery, because it will affect the absorption. And one thing we have to tell patients is consistent timing is necessary to maximize the efficacy. So the progesterone only pill, one point is it causes irregular bleeding, but patients need to be counseled that it will decrease over time. But if you see these figures, it's 70% after cycle 1 and 20% in cycle 13. So some amount of irregular bleeding is a problem. It can also cause functional cysts. This is because follicular development is not suppressed. May cause acne because it decreases SHBG, and so there's increased free steroids. But this effect is counterbalanced by the anti-androgenic action of drospirenone. Drospirenone is not associated with weight gain, and unchanged triglyceride lipid levels, carbohydrate metabolism, and coagulation factors make it very, very attractive. Then we have the emergency contraceptive method, which can be used as a backup method, but the failure rate is high, 2%. It can cause unscheduled bleeding with levonorgestrel. And remember that an IUD can also be inserted as an emergency contraceptive. I think that the copper IUD is fantastic in this age group. It's very good for women where hormonal contraception is contraindicated or they don't want. As fertility declines, you can just keep the copper T inside. There's no need to replace the device in women above 40. It's easy to insert, easy to remove, it's inexpensive. But in women with menstrual problems, it may cause more problem of little heavy bleeding and spotting, and it has no benefit at all for menopausal symptoms. Then we have ormeloxifene, and ormeloxifene is also called as centroman. Here we have no clear WHO recommendations. It's a selective estrogen receptor modulator, and that means that it works in certain tissues as estrogenic, it works in certain tissues as anti-estrogenic. So it is used for contraception, also for abnormal uterine bleeding, mastalgia, and fibroadenoma. It has some cardioprotective and prevention of osteoporosis. The dose is 30 milligram twice in a week for the first 3 months and then once in a week. It doesn't cause nausea, vomiting, and weight gain. It's safe in breastfeeding, can be taken in women of all ages, and a single 60 milligram dose can also be used as an emergency contraceptive. So has some benefits. Then we come to the long-acting reversible contraceptives. And here you're all familiar with the LNG-IUS, which has a very good effect on heavy menstrual bleeding. To some extent, progesterone can also ameliorate menopausal symptoms. Failure rate is very low, and it has a beneficial effect on endometrial hyperplasia. But remember that those who have had breast cancer, current history, it is contraindicated. Past history of breast cancer only when the risks outweigh the benefits, and not to be used in BRCA1, BRCA2 carriers on family history of breast cancer. Then it can be used as medical eligibility criteria 1. So it causes reduction of heavy menstrual bleeding, very good for women with hemostatic disorders and anticoagulants. It also may reduce fibroids, suppresses endometriosis, works beneficially on adenomyosis, reduces polyps, reduction in endometrial cancer risk, endometrial hyperplasia, and low risk endometrial cancer. It can be used for because of its endometrial protection and also prevention of pelvic infection. Now we have the injectables, which is available as DMPA once in 3 months, where there's a small loss of bone densitometry, which is regained after cessation, but not a first option in women above the age of 45 because of this problem. But amenorrhea rates are higher than other methods, up to 50% after 1 year of use, but it can be given every 3 months, and this is available in the government. Now we have the implants available, and we have the Implanon, which is the etonogestrel 68 milligram implant. And these work basically by inhibition of ovulation and changes in the viscosity of cervical mucus. And what is about the implants? The failure rate is very low. It releases low amount of progesterone into the stream. It doesn't cause a loss of bone densitometry. It's suitable for obese women and safe. Sustained release of low progestin. One thing interesting about the etonogestrel is that the return of fertility is quick and the etonogestrel levels are undetectable 1 week after removal, and it requires little user effort. So once it's in, it's in. But it's contraindicated in breast cancer. It will not give any protection against STI. Insertion and removal is a minor procedure. Expiry is 3 years. I think the biggest problem with all these are the bothersome bleeding. And if there is bleeding, you can give a combined OC pill for a few cycles to build up, to stabilize the endometrium. This is because of irregular shedding, or tranexamic acid and mefenamic acid can also be tried. And this is an interesting slide which shows you that the bone mineral density doesn't fall. It remains unaltered over 2 years because follicle development continues. So there's enough amount of estrogen to maintain the bone even with the long-term use of this. And women are likely to have changes in their bleeding pattern. As I said, they may get more frequent bleeding, continuous bleeding, and that is, I think, the major reason for discontinuation. But what we know is that they will go in amenorrhea. And after some time, so information, counseling, they have to be given so that they will accept this bleeding pattern. And remember that evaluation of abnormal uterine bleeding may also be necessary to exclude some other gynec pathology or an pregnancy. And implants have been associated with weight gain and acne, but with weight gain, it is what is called perceived weight gain. Patient feels they have gained weight because of the implant, but actually there are so many other factors: exercise, diet, aging. So studies have shown are very unclear whether the weight gain is really due to the implant, but maybe there's a small effect of increased appetite due to androgenic activity of progesterones, but the levels are very low, so unlikely. So we have to counsel these patients that they have to look after their diet and their lifestyle. Also, some risk of little acne may be more, though etonogestrel is less androgenic. But discontinuation is almost 10 to 15% per year, the most common reason being menstrual changes. Now we come to sterilization. Now remember that the whole scenario has changed now, and there's a very philosophical question on sterilization. Should we be doing it, or should we shift to LARC and SARC? And remember that because sterilization is permanent, demand for reversible procedures has increased. There is some studies which shows an increased risk of early menopause after sterilization. But there are some benefits of sterilization, like it lowers the risk of epithelial ovarian cancer. So our National Family Planning Program has been in force since 1952 through the ASHA workers and the ANMs, and Nirod is being given free, Mala N is distributed free, copper IUDs 380A and 375 are now available. Antara is available as a depot injection, DMPA. Saint Roman or Omilnexofene is available as Chaya. Easy is the emergency contraceptive pill. And of course, sterilization and no scalpel vasectomy form the backbone of our National Family Planning Program. And what I want to say is that from our Indian scenario, many years now, sterilization was the only method for women above 40. Nothing else was considered. But today we have many better methods, spacing methods like long-acting reversible contraceptives, short-acting reversible contraceptives. There are many others, and these options should be given to the patient so that it can mitigate feelings of regret that they may have that they have been sterilized. So I'd like to just end by saying that contraception after 40 is a very important thing. Do remember that contraceptives may mask menopausal symptoms. Contraceptives will also obscure the indicators of menopause, and contraception can also be a substitute for hormone replacement therapy in this age group. Thank you very much for a patient hearing. Dr. Bharti, are you there?
Hello, am I audible?
Yes.
Am I audible?
Yeah, you are audible, but you are
Okay.
from, I think,
I open my.
one device you have to close.
So I think thank you very much. Dr. Kanchan is here.
Yes, ma'am. Good evening, ma'am. Actually, my camera is not working. Some technical glitchy there. So, good evening, everyone. I'm Dr. Kanchan Prasad, and I was listening to Sarita ma'am's lecture on the contraceptives after 40, which is one of the very important topic. So, we have to, as madam has very meticulously told that we have to take care of the health benefit and contraceptive benefits, and also we have to give her the all the choices there, and at the same time we know that it will mask the menopausal symptoms during that, and it will give some benefit of the menopausal hormonal therapy also. So we have to judiciously choose, and we have to give them all the cafeteria choice of contraceptive after 40. So when we have given the details of every contraceptive methods of LARC and SARC. So thank you so much, ma'am. It was very beneficial for all the individuals and all the listeners over here. Thank you so much, ma'am. Over to Bharti ma'am and other chairperson.
So now I invite our chairperson to introduce our next speaker, and Dr. Sarita Bhalerao. Wonderful talk. Each and every slide we have revised everything, and many comments that is really very informative. So thank you very much for giving this talk. What you have me by taking latest updates, and that is really very useful. Now we come to the next speaker, Dr. Vidya Dobi. Madam, I am not able to see Dr. Shobha Kuti. Madam, maybe she's busy in some way. So I request Dr. Saroj Madam to please welcome our next speaker, Dr. Vidya Dobi.
It's a great pleasure for me to invite and welcome Dr. Vidya Dobi. We know Dr. Vidya ji very well, and we have listened her many times. She is Vice President elect of FOGSI 2025 and President of KSOGA, Chairperson of Food and Drug Medico Surgical Equipment. She has already received Best Committee Award from Dr. Marian Sotia, and there is so long list of what work she has done. And many times we have listened her, and we are here again to listen from Dr. Vidya Dobi regarding the MBA, which is very, very important subject. We all really eager to listen to you.
Thank you very much. And at the outset, I thank Dr. Parag Biniwale, Dr. Sarita Bhalerav, and other office bearers, and my dear friend Dr. Sheila Mane. And I'm very glad that many stalwarts have joined, like Dr. Ambuja, Dr. Manish Pandey, all the people, and more than 100 people have joined today's webinar. So, Bharti, you have made it very interesting, and I think your quiz everybody would like to join, and even I will also attempt. My previous speakers have brought in the contraception part, and now this is very important part, that is abortion. And I must say that Dr. Bharti has put her in her tenure. I was with her as a other chairperson of Food and Drug Committee, and she has done wonderful program all over India, and she has brought many these books also. So I'm really glad that this. I think every year she does around 4 webinars on MTP and safe abortions, and that is really useful for everybody. So today the topic is about manual vacuum aspiration and safe abortions. And this is very important for the people who work at the periphery and even in the rural areas, because it can be easily done. So globally, we all know that more than 5 lakh women, they die annually worldwide from pregnancy related causes, and most of them, around 63,000, they are dying because of unsafe abortions. I very well remember that we had done this MVA workshop at Bijapur when Dr. Kamini Rao was president, and her this one theme was safe abortions. So 5.3 million suffer temporary or permanent disability as a result of unsafe abortions. And if you see that in India, every day 13 women are dying in India due to unsafe abortion related causes. And nearly 15.6 million pregnancies are terminated every year in India. Now, unsafe abortion, which is the third leading cause of maternal death in country, contributes 8% of the such deaths annually. So this is a very important book. If you don't have, you can download from the FOGSI website, and it has got everything right from the abortion scenario, MTP Act, as well as it has got annexures and various changes and everything. And this topic of MBA, I have contributed in that, and I acknowledge Dr. Bharati's efforts in all the preparations of this book. Now, how to prevent unsafe abortion through one is very important, is a comprehensive sexuality education. Now, Dr. Sheila Mane has talked a lot about this education. Family Planning Association of India is also doing. Our Sexual Medicine Committee of FOGSI is also doing. So we have to do this sexuality education everywhere. Whenever we are talking about adolescent schools, and even in the school programs, we should include this. And second is the access to affordable contraception. Now, contraception is easily available, but most of them, they go for emergency contraception. They should know what is really needed. Though we give the cafeteria approach, but everybody should know what is a contraception, how to use it, And what is a safe abortion care? This is the third prong of prevention of unsafe abortion. So safe abortion must be provided and supported by a trained person. So training is very, very essential. Now for the medical abortions, also the training is required, because how many tablets to go take and how, what precautions they should take, how to follow it up. And for surgical procedure, of course, that should be done in a health facility. Now, what are the components of comprehensive abortion care? First and foremost is very important, that is counseling and obtaining the voluntary informed consent, which is very, very important. You have to explain them the properly what is the procedure and all the consequences. Second is a clinical assessment, obtaining reproductive health history, physical and pelvic examination is a must. Not only ultrasound, but the clinical examination is very, very important. Third is a pain management and the infection prevention. Now we all know that the sepsis is increasing, so we have to take all aseptic precautions, and we have to also manage the pain. If the patient is very sensitive, definitely we have to offer the other means offer the anesthesia when you are doing procedures. Now, uterine evacuation, the proper abortion procedure that has to be learned, and that has to be means the doctors should be trained for this procedure. Third, and the most important is detecting the complications and managing complication. This is another important prong. And the post-abortion counseling and follow-up. And the most important is a post-abortion contraception. Now, manual vacuum aspiration, this procedure is it involves the evacuation of the uterine contents by the use of handheld plastic aspirator, and it is used commonly in both developed and developing countries, and I think most of you who have joined must have been using this. What are the indication? One is the treatment of incomplete abortion up to 12 weeks, first trimester abortion, that is menstrual regulation when indicated, missed abortion, gestational age less than 12 weeks, gestational trophoblastic disease like molar pregnancy. Even in septic abortions less than 12 weeks under antibiotic cover, you can use this. Inevitable abortion, again less than 12 weeks, you can use this manual vacuum aspiration. Blighted ovum or an embryonic gestation. These are the therapeutic indications. And the contraindications are if the gestational age is more than 12 weeks, because the bony tissues and other body tissues already formed, which is very, very difficult to be evacuated via suction. The relative is if there is an infection, pelvic infection, better not to use it. And if there are coagulation disorders, these are the relative contraindications. And with precautions, of course, under antibiotic cover you can use. Now, what are the advantages? So WHO recommends that manual vacuum aspiration for the uterine evacuation is very, very useful because it is safe, high quality, affordable, easy to learn, easy to use. It is very small, portable, and it is no electricity is required, and very, very ideal for performing procedures in OPD setting. Now, what is the advantage on other techniques? There is a less pain, therefore less need of analgesia, reduced risk of complications like bleeding, less post-abortal any morbidity, less hospital stay, and it takes hardly 15 minutes. Now, these are the common whatever we use during the procedure, and we all know this like sim speculum, cusco speculum, sound, Hagar's dilator, valsellum, uterine sound, and the sponge holding forceps. So these are the common instruments which are used, and this is a main manual vacuum aspiration aspirator. Now here we know the what are the there is a if you see this picture, you will know understand how it is. There is a wall with a pair of buttons. You can see here if we can see the cursor, there are two buttons that control the vacuum. There is a cap and removable liner. There is a plunger here, big plunger with a plunger handle and a zero ring, and 60 cc cylinder for holding the evacuated uterine content with a retaining clip for the collar stop. And this is a collar stop. You can see here the collar stop here. Here, this one. So you have to pull it up. So it has got a easy grip cannulas. These cannulas, you can see here, these are the disposable cannulas, and that can be fitted into this whole instrument, the aspirator. Now, what are the steps of manual vacuum aspiration? One is we have to prepare the instrument, we have to prepare the woman, perform the cervical antiseptic preparation, administer the paracervical block, dilate the cervix, insert the cannula, and suction. Then you do the suctioning of the uterine contents, inspection of the tissue, and concurrent procedure if you want to do instrument processing. These are the few steps of manual vacuum aspiration. You can see here after the plunger is, the instrument is again taken out and put it on the table. So you can see that. So how to prepare the client? One is you have to explain the procedure to the patient. You have to take a written or verbal consent. So written consent is always better. You have to take a written consent. Then the priming of the cervix. We all know that nowadays we use the prostaglandin, which can be inserted in vagina or taken sublingually around 3 hours prior to the procedure. That reduces the risk of cervical trauma and hemorrhage. So when we don't dilate, we give prostaglandins. Now, preparation of environment and the self. Now, privacy should be maintained. Screen, because it is a OPD procedure. All articles are arranged near the procedure site. All the means patient should be prepared properly, and you have to put all universal precautions. Then scrub and wear the sterile gloves, assemble the aspirator. This is the procedure. Now, what about the pain and management? You have to talk about with the patient, reduce the pain and anxiety, and you can give the choice to the patient. It is again, you have to talk with the patient. If the woman is very anxious, she doesn't want a OPD procedure, this can be done under anesthesia also. Now, psychologically, she is very anxious, fearful. She has some apprehension about the procedure. So cervical pain will be always there with the dilatation. So if we are giving prostaglandin, some means it does not need much dilatation, and it is possible that you can insert the cannulas. Now, uterine cramping causes pain due to manipulation. So the drug should be most effective at the time of the procedure. So you have to administer any drugs 30 to 45 minutes before the procedure. So either you can give any NSAIDs or some painkillers beforehand only. So non-pharmacologically gentle, respectful interaction. This is very important. We always talk of communication skills. You have to give verbal support and reassurance, gentle, smooth operative techniques, and you can supplement but not replace the medication. Now, as I told, you can give some anxiolytic sedatives, relieve the anxiety like diazepam also, and analgesics for like ibuprofen or pentazocine, or local anesthesia. I told about the paracervical block with the lignocaine, and you can give some analgesics again. Now you have to ask the woman to empty the bladder, clean adequately and drape, clean vagina and vulva, assist her for in the lithotomy position, and conduct the first, most important is to conduct the bimanual examination to confirm the uterine size and position. Many times we find the disparity of when you don't take history properly, there is a disparity between this gestational age and whatever she gives the history. So you have to know the size and mainly whether it is a retroverted or antiverted. Insert the speculum, conduct the speculum examination, confirm the finding of the clinical assessment, rule out any infections also beforehand before taking the patient on the table. Now prepare the aspirator. This is very important. The priming of the aspirator is very important. You can see on the right side, the position of the plunger all the way inside the cylinder, right? So have a collar stop in place with the tabs in the cylinder holes. Push the valve. I don't have in my hand, otherwise I would have shown. Push the valve buttons down and forward until they lock. Pull the plunger back until the arms snap to outward and catch on the cylinder base. So whatever you can see on the right side, once you this one, there will be a snap outward, and then there is a negative pressure inside this is created in the cylinder. Now
Yeah, ma'am. You're muted.
Dr. Vidya, please unmute yourself.
I don't know since when it became unmute from this.
No, this only.
Acha,
This
I
year.
explained this, na? Okay, okay. So I explained this. So there is a negative pressure is created in the cylinder, right? So now you have to follow no touch technique. No instrument that enters the uterus can contact the contaminated surface. So once you put the this one, you have done the priming of this aspirator. You have to attach the cannula to this. Before that, you have to clean the cervix. You can see the antiseptic soaked sponge to clean the cervical os. Start at the os and spirally outward without retracting areas. You have to continue till the os has been completely covered by antiseptic. Now we have to give the paracervical block then. So this paracervical block is recommended when mechanical dilatation is required with manual vacuum aspiration. Otherwise, if already you have done priming with prostaglandin, many times it is not needed. So using local protocols, you can administer the paracervical block at 2, 4, 8, 10 at o'clock position, and you have to place the tenaculum. Use the lowest anesthetic dose possible to avoid the toxicity. So lignocaine should be avoided, means you should be given at the lowest possible recommended dose. Now, what is there is a dilatation of the cervix. As I told many times, it may not be required. Already with the prostaglandin, it is dilated. You have to put the cannula inside the uterine cavity. The greater the gestation of the pregnancy, the greater amount of dilatation may be required. Dilate the cervix to allow the cannula approximate to the gestational age to fit snugly through the os. If cervix is insufficiently dilated, use mechanical dilator or progressively larger cannula to dilate. Now, usually what happens is roughly the number of gestational week is the number of the cannula. So 7 weeks, 7 millimeter is the cannula size. Now, then comes the suction of the uterine content. This attach the prepared aspirated to the cannula, and the cannula and aspirator were not previously attached. So you have to attach the cannula, put this inside the cannula, and then you have to release the vacuum by pressing the buttons. Evacuate the content of the uterus by gently you have to rotate the cannula 180 degrees in each direction using in and out motion. So you have to rotate it and you have to move it properly. The signs we all know that it indicates the uterus is empty. One is red and pink foam without the tissue is seen passing through the cannula. You can see it is coming out and it is coming in the aspirator. Gritty sensation is another one. It is felt as the cannula passes over the surface of the evacuated uterus, and the uterus contracts around or grips the cannula, and the patient complains of cramping pain, indicating that the uterus is contracting. So uterus contracts, there is a gritty sensation, pink foam comes, and the size of the uterus decreases. Then you have to slowly release the button, empty the content of the aspirator into the container. Now this material to be strained, float in the water and then view with the light from beneath. Inspect the tissue for the products of conception and complete evacuation and molar pregnancy sometimes, and these to be sent for the histopathology. Perform any concurrent procedure, and when the procedure is complete, proceed with contraception or other procedures such as intrauterine contraceptive insertion, or if any cervical tear repair also can be done. But usually I don't prefer the simultaneous these operations. So process means I do tell them for the contraception, but this cervical tear repair and all no simultaneously we need not do. The process instruments immediately process or discard all instruments according to the local protocol. Now, how to sterilize the instruments? High level disinfection in 0.5% chlorine solution, or you can boil them. High level of disinfection in Sidex. Sidex is preferred, and or you can do even autoclaving, but 121 degrees centigrade for 30 minutes, or even you can do sterilization of these cannulas with ethylene oxide ETO sterilization. Now, aspirator discard or replace if there is a brittle, it has become brittle, cracked, or if there are mineral deposits, wall parts are cracked, bent, or even buttons are damaged. So, if the aspirator no longer holds a vacuum. It creates around 600 to 800. So that much vacuum has to be created. The cannulas also can be discarded, and actually they are disposable, but you can use it, and you can sterilize it properly. And if they are also damaged, particularly aperture, you have to clean them. So cleaning of the cannula, I just finished. Cleaning the cannula does not completely remove the tissue. So these are the components, complications. You know about the complications. You must know whether you have perforated, there is a loss of resistance. You have to immediately detect it, and then you have to tell also, and you have to treat also. The counseling is very important to identify, to respond to the emotional and physical health needs. Contraceptive and family planning services to help her prevent future unwanted pregnancies or miscarriages, reproductive and other health services provided in the facility or referral, community and service provider partnership, mobilizing resources to ensure the timely care. Now, this is very important slide. I have put it here, that approach to MTP. This is a flow chart. Whenever she comes, confirmation of pregnancy, gestational age, then indication, then you have to provide counseling, and you have to take consent. That is very, very important. Form C and Form I. You have to check the what means. Then you have to counsel about the give the services along with the contraceptive advice. So this chart you have to follow always. Litigations, how you have to avoid. One is counseling, second is documentation. You have to improve your skills and know about the act. These are the four components. And I think I will be able to, I don't think it is playing, but this is a procedure, the demonstration, you can just observe it sometimes. I will be able to do it. Now, family planning alone could bring more benefits to more people at less cost than any other single technology now available in the human race. That is what the UNICEF says. So every time you do any procedures of medical termination of pregnancy, you always counsel them, and without providing any contraception, please say that we will be at fault if we don't counsel them about the contraception. So let us create a world without an unintended pregnancy. So thank you for the patient listening, and thank you, Bharti, for all the efforts you are doing for this, and thank you for everything. Thank you very much.
Thank you so much, Dr. Vidya, for such a detailed description of regarding the manual vacuum aspiration and its procedure. You have described everything very nicely. I think for OPD procedures for small size uterus, it is very good procedure. It can be used at many places. Thank you so much for being with us. Very nice.
Thank you very much. Thank you very much.
Thanks, Bharti, for
Thank you
making
so
me a
much,
part of this.
Thank
Thanks,
you, Vidya
Bharti, for
ma'am.
making me a part.
It was very informative, very informative talk. And at the same time, I also want to congratulate Bharti ma'am. She has
Yeah.
taken all the topics, very relevant topics.
Yes. She has taken all the efforts to do everything from A to Z. She has done.
And so it's
Thanks,
very,
Bharti,
very
for making
informative topic. All the topics are very relevant, ma'am. All the topics in day-to-day clinical practice.
Yeah.
So,
Thank you. So now it is, acha, panel is there.
Thank you very much, Dr. Vidya. Wonderful talk, and you have fulfilled my aim that I know that everyone should know about MBA, its advantage, how it should be used, how it should be maintained, and of course, post about the contraception. Thank you very much for you have covered. In the last panel, if I would get opportunity, I will run the MBA video. Now we move to our next session on this very important ICOG webinar on the contraception, that is panel discussion on effective use of contraception. Nilima, please, So moderator, myself, as you all know that I have done the work in the MTP committee, and Dr. Milind Shah is the expert in this panel. If he is available, then he will join. We all know Dr. Milind Shah, past FOGSI Vice President. Professor Shikha Singh, she is a professor and head of department, SN Medical College, Agra. Welcome, Dr. Shikha. And you are always available for the academic programs, and you have done lots of achievements and awards like FOGSI Indumati Jhaveri Prize, Indira Gandhi Woman Achiever Award, FOGSI CS Dawn Prize Award. So very academic and involved in the research academic publications. Next, please. Next, our panelist is Professor Dr. Nalini Sharma, Madam. She is in the professor in the Shillong Medical College. Welcome, Madam. Next, please. Dr. Priya Gupta, she is not available due to some family reason. Next, please. Dr. Anita Gautam, she is a CMO at the GSVM Medical College, Kanpur. And I am very fortunate that she is just next to me in the LLRM Medical College doing her post-graduation. Welcome, Dr. Anita Gautam, and she is doing work at a GSVM Medical College as she has worked a lot for the as a family planning officer as well as nowadays she is a CMO there. Then Dr. Deepali Srivastav, she is in the KGMU as a family planning officer. And Madam, are you there? Dr. Deepali, you are there?
Yeah. Okay,
Yeah,
good
so
evening,
please
everyone.
you tell something with which I don't know about you. You are currently at the KGMU.
Yeah. I'm
Yeah.
in charge postpartum unit in KGM,
Yes, so you are
since 2003.
I must say that knowledgeable person for this field. Next, anyone, please. Dr. Richa Singhal, she is a renowned practitioner and at Noida. And in fact, I have invited in this panel not only from the government setup, but like other specialists. Like Richa is known for
I'm a
uh,
obstetrician at
fetal
Cloud9
medicine
Hospital.
specialist, what I know her. So
I'm
I invited especially with this purpose that we will take an input of how they are contributing in family, how they are contributing in family planning services, and I want to motivate all specialists in the obs and gynae also that please contribute. So we come to the our panel, that is the panel on especially how to effectively use contraceptive methods what we have. So we have already, I introduced my all panelists. So welcome all panelists. And in next 30-40 minutes, we will try to give some informative input and as well as some take home messages that how we should make a family planning program more effective. So we all know that contraception is the deliberate use of methods or devices to prevent pregnancy by interfering with the normal process of ovulation, fertilization, and implantation. At any stage, you can see in the diagram from ovulation to implantation, if we hinder, then we can stop the pregnancy. If we see the current scenario of contraception, you will be surprised to know that an estimated 2 million women in developing countries would like to delay or stop childbearing, but are not using any method of contraception. And that is only just because of either limited choice of method, limited access to contraception, fear or experience of side effect, cultural or religious opposition, poor quality of available services, and gender-based barrier. So this is not issues in only our country. This is a global issue. And you will be happy to know that India was the first country to introduce a family planning program in the world. This was the first country. And if you just have a view that here you can find out different states, they have contributed for population. So you say that in the all over country, the Uttar Pradesh has contributed total country's population of 16%, followed by Maharashtra 9%. And rest Bihar also 9%, West Bengal 8%, then Andhra Pradesh 7%, Karnataka 6%, 5%, Rajasthan 6%, and the rest then 2 to 3%. So this is the population share of the state. And if you see the trends in the prevalence of these contraception, then you will find out that percentage of contraception acceptance, of course, in the Andhra Pradesh, Sikkim, Kerala, Karnataka, they are from 50 to 55 to 60%, which decreases into the Jharkhand, Bihar, and Uttar Pradesh around 28 to 30%. The reason is very simple. Where the population is more, we have more challenges and we are not able to achieve that target which in the less population. What is the current unmet need for family planning in India? Here again, you see that Uttar Pradesh, Jharkhand, and Bihar, it is 33 to 38%, while in the less, the unmet need is very less, 8 to 12%. In some cases in the south, it is 19 to 20%. So as we have less challenges, definitely we are doing well. Current use of family planning methods is all over country, you will see that non-user are 46%. Still, this is a big challenge, and in fact, objective for all of us to how to make them available, make them accept the contraception. As well as you see, female sterilization is still 34%, but male sterilization only 1%. And the pill 4% only all over the country. The only acceptance of pill is 4%, IUD 2%, and condom 6%. Any other traditional method 7%. And unmet need is 13.5%, and 8% is basic method. So you can find out unmet need is 21.5%. So with this background, we come to the today's panel that from and panelists one by one, how you can utilize opportunity, because you are saying that for we are the first one who have introduced family planning program in India 1950. Until there, in 2025, we have only acceptance of less than 5% of family planning method. Though the government and we all are doing government sectors as well as private sector, so called, they are doing best effort. So what the I want to ask each one of you, how or anyone, how we can utilize the opportunity to counsel for the contraception, what contraception and when, how, and what is your experience, where we are lagging. We start from Dr. Deepali Srivastav.
Hello, good evening, everyone. And thank you, Dr. Bharti, for giving me this opportunity. Actually, we are doing counseling at every level, but we are not getting the proper result. That is what that we are giving the exposure to the patients, but we are not getting the proper response. So somewhere we are lacking in our communication.
Okay.
Probably it's because in busy OPDs we are not giving them enough time, or during the delivery or postpartum period we are not in
Okay,
the
so Dr.
much
Deepali,
contact
you
with
have
them.
put very important point. The separate counselors are not there, what you are
Yeah,
saying, or
that
shortage is there.
for
So
this,
enough
yeah.
time, yeah. And target clients, we are not able to pick them because you have to do lots of clinical work, also family planning team and all. Dr. Anita, what you say that what we can do?
Ma'am, as a obstetrician, we can counsel the woman for contraception in her antenatal visit, intrapartum and immediate postpartum visit, or any gynec OPD when she came for the menstrual problems or other problems. At every level, we can counsel her for the contraception, ma'am, as a gynecologist. And
So, Dr. Anita, I just want to say that if you, what the best time you find out that where you can do counsel, and what message you want to give, your what is in your experience when the women accept the or they want to hear about the contraception?
ma'am, the best time is at the antenatal, at the time of antenatal visit, when she came for examination and all. Then we can say her that after this pregnancy, please keep the gap between the two pregnancy at least for 2 to 3 years, so that your health become good and your baby grow well. And this is the best time. And also at the time of intrapartum and immediate postpartum period, we can counsel her, because us समय she knows the pain of delivery and all, so she is highly motivated for that. So we can counsel her at the time of postpartum, just after delivery, within 48 hours.
I think,
Like,
in my opinion, there is just one point to add. Everybody is saying the right thing. First, antenatal visit is whenever patient comes for the antenatal visit, we must tell her about the methods, contraceptive methods. But I think also there should be some information brochure or booklet which should be published by the gynecologist, or मतलब हम अपने पास रखें, that should be given when we are
Displayed. Yeah.
either display, or we give them, because like I'm a private practitioner, I am providing one antenatal, you can say the card is there, then I give her exercise chart and all those things. Along with it, we should also add one contraceptive, a pamphlet containing a variety of contraceptive methods and their benefits, so that will
Risha,
also.
if you do you really do, so I am really proud of you, and
I do
I
it.
think that
Yes.
we all should do that. Definitely, it will definitely help, because most of the time in the OBGY practitioners, they think that, or the government sectors, we think that is their duty. So if we all do, definitely. So what I could get, Dr. Nalini Sharma, you are here? Dr. Nalini, Professor Dr. Nalini.
Please
Madam?
unmute yourself.
Yeah, Nalini. Nalini, madam, you are there?
Yeah, she is there. Please, Dr. Nalini, unmute yourself.
Yes,
Bharti,
please.
Dr. Ambuja wants to say something. She has raised
Yeah,
her
please,
hand.
madam, welcome. All of you can say something. Please unmute
Yeah,
yourself.
please allow her, no? Please unmute her.
Unmute her. All are allowed. Please unmute yourself.
Good evening.
Yeah.
Good evening, everybody. Thank you, Dr.
Yeah. Yeah,
Tabbi, for
I
allowing
am
me to talk.
I am a
And
faculty in a teaching institute, and my experience is when our PGR resident they do counseling, and when we do counseling, so patient motivates with us. Basically, I use always diagram and charts and show them. So, like oral, yeah, verbally we can't count
Counsel.
tell the patient.
They listen
Uh,
and they forget usually. But if
we can
you
use some charts and diagrams and how what is the
retain with
mechanism,
them,
then then acceptance rate will be very high.
it retains with them.
good
Yes,
evening,
and
Dr. Vidya Tabbi. Can I speak? I'm Dr. Ambuja.
Yes,
please,
Hello.
Dr.
Yes,
Ambuja.
please, madam. Yes,
Yeah.
please, madam.
Uh,
Please,
and, uh,
please.
Good evening, everybody. Dr. Bharati and Vidya for giving me the opportunity. Thank you very much. Regarding counseling, what my experience is, because I worked in a very big government hospital where every day about 4,000 antenatal OP is there, and none of the patients they like to hear about the family planning in the first and second antenatal visits. All of you, you judge yourself how you are. Maybe you will be able to do in a private setup. I don't know. No antenatal patient wishes to hear about family planning in the first and second antenatal visit. They want to know more about the antenatal problems and all. It is only the best period is the postpartum period, not the antenatal. They don't like it.
Yes, madam. I agree with you.
Oh.
And this is really big challenge. Though we have thought that these patients we can counsel, but patients actually are not willing to hear about that. Anyhow, we should find out some way to attract a woman so that they are willing to hear about the contraception. I agree. Because once they come, so they are mainly concerned with their antenatal times and their ultrasounds and their Dopplers. Even so, I don't know what could be the most appropriate time, but I could get only that conclusion that we should continue to do our effort in each visit, and that is also good thing. We can give the writing pamphlets and anything because sometimes they don't want to hear and they don't get time. So even in the antenatal cards or even the postnatal care cards, we have some information on the back of it. So and some posters and visible things where they are waiting so they can get some time. They can
Actually, we
read that.
have counselors in our hospital. We have a dedicated counselors. They don't express the same thing to the doctors, but to the counselors, they say, "What the hell you are speaking when I am pregnant? Do you want that we have to abort or do something like this?" That's what is the expression many patients express. So it just
There
we
are a
can
lot
tell
of
the
myths
information,
attached.
but I don't
Yeah.
think we should
Shikha,
explain
you
that.
want to add something after that?
yeah. I think when the patient
Madam Ambuja, we are
anti
agree that counselor has really great role. Yes, Shikha.
Yeah, when the antenatal women, which are large in number in government institutes and also in large private hospitals, when they are large in number, then we can have a video display on the TV screens during the waiting hall. That is an indirect method in which they are not being influenced directly by the counselor or the doctor. As Ambuja ma'am rightly told that during the antenatal period, they are not very receptive when it is being told directly by the doctor or the counselor. But when they are seeing it on the screen and during the waiting period, they get a 10-minute video. So they keep it in their mind that right from the postpartum, before the discharge, we will take some option so that the next pregnancy has a
Yes,
proper
yes.
spacing.
But still,
We do
there
have
are
all those
There are other
provisions
things
in
also
the
which we
waiting hall.
display during the NC period of the patient. So most of the times the videos which are being played are about lactation, about what to do, what not to do during pregnancy.
During pregnancy.
Contraception takes a
so,
back seat
Yeah.
actually.
so
Ah.
it is in all family planning panel. This is the most important challenge that how to attract the woman. We make material, we make the things, but how they listen you. So that is important. Even in the sometimes I have done, of course, I'm in the private medical college. I have a special counselor. We have two counselors in our OPDs and all areas. So we have made some form that where they give them supplementation, iron and calcium, folic acid, so we ask them to, you have to tell these questions and you will get it. So they have just, this is a formality and they little bit sensitized for that. Though even they are not clear ki what they will take, but of course, we continue to give information
We
as we
will be
have limited time. So we focused on the other issues. So here I have just message that whenever we are doing counseling, even we are getting 2 minutes, please utilize it for the providing accurate information on available, addressing myth and misconception. क्योंकि हमने बताया IUCD है, लेकिन they knows कि ये तो it is not good और ये ऊपर चढ़ जाता है, it migrates and etc. Involving partner in decision making. Try to utilize that important time, even if his husband or family members like those, sometimes even
lost.
mother-in-law, they also take
Mother-in-law should
decision.
always be included in the discussion, which is very
Discussion.
important.
And
Because
emphasizing
they
the
are
benefits
decision
of
makers.
spacing pregnancy.
Even
And
while
of course,
providing, yeah.
yeah, and
I like
counseling
to
for contraception
Well,
success.
also.
I educate postpartum lactating women on limitation of lactation amenorrhea method. Many postpartum women experience unplanned pregnancy due to false perception of reduced fertility. We all know that. And the counseling of contraceptive success, that strategies that may increase uptake and continuation of contraceptive use include counsel thoroughly all methods, even if patient state a preference for a particular contraceptive. Whenever you are getting opportunity, ideally time is when patient is coming for follow up, only 2, 3, 4 minutes. It's too exclusive for the counseling. Encourage long-acting reverse contraception method having top-tier effectiveness. Avoid bundling or unrelated preventive care. Pap smear with contraception initiation. Avoid unnecessary delays of waiting for a menstrual period or a follow-up exam after a pregnancy. And the counseling for contraceptive with encourage dual protection, particularly young women. Include male partner in counseling when possible and appropriate. Dispense advanced EC emergency contraception if possible, giving advance EC prescription to all women under age 18. And she can choose a method from available family planning method that can start it at once. If a woman decide not to use contraception at that time, providers can offer information on all available method and from where to obtain them. Providers can offer condoms, OCPs, or emergency contraception pill for women to take home and use later. Method specific counseling should follow if she choose any family planning method. And gather approach, we all know that it's very important that we should, and Government of India, they have done lots of communication campaign and like that, Facebook web page, print app posters, outdoor campaigns, celebrities, WhatsApp videos, television ads, 52 weeks long radio chat show, toll free helpline numbers. So we all practitioners, they also should utilize in our practice, in our clinic, these governments, these helplines also. And nowadays, any panelist, Dr. Shikha, what the government in the short, what the government has options, and is Richa, is women is you are giving them some government options, or you are always ask them to take something from market or purchase, and what more should be used to increase contraception acceptance? Yes.
Yes, Bharti ji, the government on in the family planning national program, which was started way back in 52, they have numerous options available, right from the male contraception, the barrier contraceptive Nirod is available, and in the female contraception, the combined oral contraceptives Mala N is available. And also from recently, more than 7, 8 years, new addition like Antara and Chaya, which are the injectable DMPA depot metroxyprogesterone acetate, and also Chaya, which is the non-steroidal Centroman that is developed by CDRI Lucknow, that has been available. And also the permanent methods, both male and female sterilization, they are available right from the PHC, CHC level district hospital and also the medical colleges. So the variety of options, the basket of options is all government institutes, right from the PHC, they are giving, and they are also in ample supply, all these options.
Yeah.
Thank you very much. And I just want to highlight all of you. I just want to tell you that government has policy level. It has target-free approach, voluntary adoption of family planning method based on felt need of community, children by chance, choice and not by chance. India is the first country to launch this program. At the service level, more emphasis on spacing methods, assuring quality of services, expanding contraception choice. Immediate addresses unmet needs, which is the objective of family planning policies. And in the midterm, that is the TFR to replacement level of 2.1. Total fertility rate by 2010. And long term, it is that population stabilization by 2045. This is the government policies, and expansion of basket of family planning choices are already done, augmenting the demand through Aisha scheme for family planning. They have promoted quality sterilization services, promoting quality IUCD services, generating demands and awareness for family planning services. This is very important thing. Where we have to focus, we have to generate the demand. How we have to do, we have to see that. Addressing global commitment, family planning by family planning. So this was very beautifully you have told. And here just in the last, I want to highlight that government has, this is the NHM poster where they have shared that ensure equal participation of men and women in family planning, reduce undue burden of women by adopting condoms and male sterilization, as well as discuss with partner and jointly decided whether, when, and how many children to have, reduce the financial burden on a family, so share the responsibility for healthier families. This is the government motto. And but still you can say that in our countries, if we say the modern contraceptive prevalence rate acceptance in India, it is only 38.7%, while in Bhutan in the 50%, while in the Bangladesh in the 40.8%, Sri Lanka 52%. So definitely we should do more efforts. When these countries can do, why we not? Prevalence rate of sterilization in India, if you see, in comparison, it is 36.9%, while in US and China, it is around 33-34%. And the contraceptive method in India, only 3-4% IUD, 7-8% pill, 11-12% condom. It is really disheartening. So this is the thing. I think these are the, we have limited time. So we will discuss the other things, important options. So we all know these are the, what is the approach to provide contraception in any case. Dr. Deepali, what is the approach in the short? How we should provide which contraception to which woman? How you decide?
We have a list of medical eligibility criteria for this, in
Mm-hmm.
which we find that IUCD has the least side effects, and like IUCD can be given, but it is attached with a lot of myths. So I think before providing any contraceptive, first we should go for a good counseling, just to take a proper history, proper
Mm-hmm.
contraindications, side effects, and according to that, and according to the need of the patient, we can give them the contraceptive of choice.
Very true. And in fact, what you have discussed, this is from government websites. I have taken out the strength of our system. So definitely, as you said, that for regarding counsel providers, knowledge and skills, which is adequate, that is NM nurses and doctors training, but inadequate is still counseling skills often poor. And even some are uncomfortable in discussing contraception with unmarried or adolescent women. Incorrect beliefs persist among providers also, refusing IUCD for nulliparous women, overconscious with OCPs, insufficient knowledge about Tantra, side effects management, inadequate training in medical eligibility criteria, lack of experience with LAM, emergency contraception, postpartum family planning. So we have to work out here. And then we comes to, yes, MEC, we all should be familiar about this, and we should train our staff and all doctors, youngsters about that. Even I did it outside the gynecologist. All MBBS, all if any specialty doctors, they should be trained about this MEC, and they should train their staff so they our large population can be covered. So any role of any panelist about the sexuality education in adolescent, is it affects our acceptance of contraception?
Yeah,
So
nowadays,
Yeah,
yeah, Dr.
sensitization should
Nandi.
be started from adolescent. What I
yeah,
believe is that
sex
from
education
school we
should,
have to, yeah. Along
yeah,
with the
in the
sex
school.
education, we must tell
Dr.
them
Ambuja,
about
Dr.
the
Nalini, all of you,
The,
views,
contraception.
anyone.
yeah,
Yeah, we
yeah,
should start sex education and safe sex and
Sensitization
plus
is one.
contraceptive methods available, because nowadays they are getting puberty early. So it is very much
that's
In
a
relevant
private practice,
nowadays.
in private
yeah, that's
practice,
a big
normally,
issue. That's a big issue. Hi, I'm Dr. Ambuja speaking. There's a
Mm-hmm.
big issue going on in the Family Planning Association of India. I don't know how many of you are aware of it. I was there as a vice president, All India Family Planning Association, and we allot in every society of family planning. This is the main thing what we preach to all the adolescents. We adopt the villages, go to the particular villages, collect all the adolescents and teach them about the SRH programs, that is sexual and health reproductive programs that we teach. And one of the program is about teaching about the sexual health and then about the family planning. That's what is the thing that's going on. And we do a lot of sexuality education, go to the schools and teach them. Mainly the government schools where the attention is very much less compared to the private schools. This is what we do it in all the family planning devices, not only in Hyderabad or in Delhi or Bombay. We have a central thing is in Bombay and all the other places we are doing. This is on a prime basis which we are undertaking this right now.
So we all agree that comprehensive sexuality education definitely it reduces unintended pregnancy, but how to give, where to give, definitely in a country like India, it is challenge, but we are finding the way. Premarital counseling improves informed decision. I always believe that there should be something that at the marriage places and in the picture theaters, in the some the ends or the in any public places, even the youngsters before marriage and after 18, 19 years or around that, they should get, adequate information about the contraception and at least sensitization. Adolescent friendly clinics are essential. This is a place where we can do the sexuality education as well as for the adolescent contraception, promote responsible reproductive choices.
Yeah,
I think
So
it is
nowadays,
just
there
one
should
more
be a
thing I want to
counseling
tell.
centers for
One more
this.
thing I want to tell.
Adolescent clinics must
All
be
the time
there.
we
They
are,
are very
Yeah,
important.
there is
yeah,
schools.
all the time.
Normally the adolescent girls, whenever they come to us, they are either with their mothers or they are accompanied by somebody who is taking care of them, and we are not able to tell them very clearly about contraception, since a mother will always become curious why are you telling her about. So adolescent
Nee,
clinic
Dr. Isha,
definitely, yes.
yeah, we will find out the way because we have only 5 minutes left.
Hmm.
So
Bharti,
we have
one
to
more
take
thing
the
I just
issue.
want to tell. Bharti, one more thing I want to tell. Always we are concentrating on the school children only. What about the out of school? That is,
Yeah,
the beggars are there and street vendors are
awareness is
there.
the
So
most.
many things. That's what we are concentrating in the Family Planning Association. We go to the railway platforms or to the bus stations. We'll enact the programs to them. Many children are street children are there, so they
Definitely.
need lot of attention for that one, because many of us are going to the schools, colleges and all, but nobody is caring for the street children, beggars and out of school children. So these are the people whom we need to give lot of attention, and government of India has to give lot of importance for this.
So
Yes.
definitely by this panel, we have sensitized about the adolescent education as well as it is really a need that we should give some information, correct information, so that we can avoid the unintended pregnancy as well as unsafe abortion and as well as unintended pregnancy. Then comes to the next oral contraception. We know that what is the mechanism of it: inhibit ovulation, thicken cervical mucus, thin endometrium, emergency contraception, and non-contraceptive benefits beyond contraception. So we all are aware of different generations of OCP. Nowadays we have Mala and Mala D as the second generation. Third generation we have Femilon, Loet, that is the low dose generations, and the fourth new generations. Also we have, Madam has told in the over 40 is very good, estradiol, dasypyrenone. So type of progesterone also we know they have all different advantages, and this is very important. Our Asha NMs health workers, they are many much are trained about that how to guide the women about how to take pills and how they actions. And here we have find out the way in our colleges nowadays, through the as our women registers for anything, we send them on the WhatsApp some information. On the digital media, we also can send them, particularly individually to them information. Non-contraception benefits of the OCP, that is the
Yes.
actually a very good method to attract the woman for the contraception uses, and we do also in the postnatal women or in the interval period or in the reproductive age women. And already we have talked about the contraception in adolescent as well as in the postnatal women. So in adolescents, I have some very good slides from madam has told in fact the contraception in adolescent detail about the Dr. Sheila Mane madam in this session. But it always we should offer dual protection, contraception plus a step protection, as well as counseling should be confidential, non-judgmental, as already our panelist has emphasized. So we have option for them: condoms, COCs, long-acting reversible contraception, and progesterone only pill. And IUDs also nowadays we are giving them, and by WHO and all, it is said that it is safe in early paras adolescent, and that is good. And emergency contraception, definitely they have very good role. So correct information in the health workers as well as in women, and providing them in advance, that is very useful. It is found in many evidences and studies. And copper IUCD within 5 days. If it is done after an unprotected act, then it is very effective. Best utilization in adolescent, it can be done. And post-abortion contraception, I always found that though the after delivery, it is sometimes women are not receptive, but post-abortion, they are very much receptive. And nowadays, when you start the even medical method, so when you give the misoprostol, even for that day, you can start the OCPs or you can start the contraceptive method. So you all must be, all obstetrician and gynecologists should be aware that what methods can be started immediately, what methods after some time, like IUD, after medical abortions, pills, they can be start immediately after abortion. Injectables can be given the same way. Provide 3 month protection. Implants insert immediately after MVA or medical abortion. Condom, emergency contraception can be used immediately. Of course, sterilization little late, and best use in post-abortive client. I always find implant or immediately intrauterine devices, LARC. They are very good long-term reversible contraception. For medical abortion patients, we can give condom pill until IUD insertion. Emphasize dual protection and STI screening, ensure follow-up for IUD excursion. So PPIUCD ka role, Madam Dr. Shikha, what is the role of PPIUCD? How, like we were using interval IUCDs and all, how PPIUCD can affect our country scenario? In brief.
PPICD, actually, we take the consent just before delivery in all those women who are willing, and it is inserted right after the delivery, whether it is a vaginal delivery or during the cesarean section. And the receptivity when the patient comes in labor for giving the compliance and giving the affirmation is high. So we have a good number of PPICDs inserted after C-section or a vaginal delivery. And after that, the rate of coming for withdrawal is also less if it is at that time, because after delivery, the bleeding pattern will be a little disturbed and prolonged
Masked.
bleeding. So that is masked
Dr.
by the
Anita, short, brief. Dr. Anita, your experience, Dr. Deepali, your experience for PPIUCD. Good, recommended, acceptance is there or not?
Yeah, their acceptance is good, but later on they usually come in follow up. But if they are for removal, but when they are counseled or when they are told about that the postnatal period is something with the irregular period, then they are easily convinced also.
Ma'am,
So
Dr. Anita?
PPICD is
yes,
doing good.
ma'am. It is extremely effective and failure rate is only 0.5 to 1%, and it work immediately. No interference with breastfeeding, so it is highly accepted.
It's
And
really
it's
Dr.
accepted.
very
Nalini, you are there? Yeah,
Yeah,
good,
yeah,
good.
I'm
You
here.
have said.
And we are also doing counseling for PPICD, and it is very much accepted by the woman. And one more thing I'd like to highlight that recently we are having WHO project for implant. So like implant, they are like very much, and acceptance rate is quite high with implant also.
So, okay, if we do proper counseling and if we select the patient, I am very much fond of this because
Yeah, yeah.
many patients, around 60-70% patient, those we have inserted, they continue it. So,
Yeah.
this is very good thing that they can avoid the unwanted pregnancies even in the lactational periods. And all of we continuation at 6 months, it is 70 to 80%. And we have done lots of researches also, and that is, but patient counseling should be proper. So they improve satisfaction as well as they can, if they
Yeah.
have any issues, so the continuation is more. Role of long-term reversible contraception versus sterilization. दीपाली जी क्या कहते हैं आप आपके यहाँ आजकल
लॉन्ग
क्या
टर्म
चल रहा है?
आजकल तो फिर अब कंट्रा वो स्टरलाइजेशन इज का रेट हैज बीन डिक्रीज नाउ because of the less kids in the family, like 2-3 बच्चों पे ही they come for this, so it has decreased and they are more towards the long acting reversible contraceptive.
Right. And our scenarios also, the people are preferring large, and
Yeah.
even we prefer that for 10 years. Their kids are small. We think, and they are very good LNG, IUS, and they were available 380A in the government supply also. So we are very happy with this.
Even
Completely
with the
reversible.
injection mantra, they are very happy, and they usually they come with
Yeah.
about every 3 months for
And
this
yeah, and it is
injection.
completely reversible with rapid return of fertility. So very good. I always give, but there are lots of myths associated with it. So only we have to handle that.
Cancel them,
So
yeah.
that is things. A natural method of contraception. Dr. Anita, LAM, lactation anemia method. How much you emphasize in your hospital, and Dr. Shikha, we all are medical college person, so we are little bit more aware of that. So is it so, LAM and barrier,
Yeah.
how much you found helpful?
LAM is actually scientifically proven postpartum contraception method. Uh, Three criteria should be met: exclusive breastfeeding, day and night. In day, not gap should not be more than 4 hours, and in night not more than 6 hours. There should be amenorrhea, and the baby should be less than 6 months. That only that
And
it
there should be
work.
no bleeding. Yeah, amenorrhea. Yeah.
Amenorrhea should be there, and it is
And
hmm,
yes, till I
hmm.
take next question, I request Nilima or ICOG office bearer, please put quiz online quiz link in the chat box, or our team, Dr. Vanshika, please put that in the chat box if you have. So till that, it would be submitted by those, they will get the e-certificate regarding that. There are only 10 simple questions. You can send it to the, you just had to fill it and submit. So lactational amenorrhea method, through this panel, I just want to emphasize and just want to give message that everyone should be told about this, and you should have in your clinic posters about this. That is, woman, if she is having all these three criteria, like she is doing exclusive breastfeeding at least once in a night. No top feeding, amenorrhea means when till she is having amenorrhea, but it is effective maximum up to 6 months. Even she is having amenorrhea. But if she gets menses after 2 months, 3 months, then it is not so effective. It is so, then it provides 98% effectiveness under ideal conditions. So you can find out that it is so good, and it is additionally getting advantage of breastfeeding. So this is one thing which we all should know. Barrier methods, of course, it is important because it gave, prevention from STIs as well as additional protection. So, but alone if it is used, then it is success rate is less 80%. Then emergency contraception. Dr. Nalini, how you found it useful in our national scenario? How high pill can or emergency contraception can be useful?
In India, out of three, one pregnancy is unintended pregnancy. So, an unmet need is also there. Is very important. There is a definitely role of emergency contraceptive in population stabilization. So, we can raise awareness about, and it is
But it
very
should not
useful.
be taken as a contraceptive. One
So
thing that otherwise they
It
will
will
come
not to
with
take, but
horrible
random,
bleeding. Yeah.
the
because
emergency
there
Should be in
in
their
contraception does
mind
not
that
menopausal,
it's
replace the
not a
regular
in
contraceptive.
perimenopausal woman, plus the when the husband and wife not living together, like random sex, then it is very much important and useful.
Mm.
emergency
Yes.
contraception does not replace the regular contraception, but it plays a
Yeah,
critical support
definitely.
role
But
in preventing the
it is having
unintended
role. It is having role.
pregnancies,
Yeah.
which directly contribute to
Okay,
the
so we
population
all
stability.
agree that awareness about emergency contraception, availability of
There.
it to the
Yeah.
client, and as well as proper counseling. That yes, ICD had sent the link. They are very smart persons. Thank you, but I still do. Yeah. So I think that awareness should be there, and but it is only backup method. They should be written very well everywhere, and to all health providers they should be given with caution that they should get proper counseling. I always found that all counseling material should be written down because once we pass, then it is never passed as such as we want. So it should be in the writing and in the short, in their local language. Only then we can fulfill our purpose. So till what age women can take contraception safely, how to select, ये सब हम लोग we have already discussed. Role of contraceptive counseling to male partner. So we all agree that male partner is very important. So I found two important message in today's panel. One is that the involvement of family and male partner, where we are lagging. And second thing, that I was told that role of counselor, special and separate counselor, and proper material should be displayed in the social medias, in the walls, in the public places, because women are not have enough time, or they are keen to listen by separate time in the separately for the contraception. So once they are sensitized by any message or any method, they will ask to take more information by that. So, Dr. Shikha, in how you are doing efforts or you want to do efforts for involvement of male?
Dr. Bharti, I would like to add one of.
Sorry.
Hello.
Uh-huh.
Ah,
Hello.
okay. Most of the
Deepali ma'am.
time, when, yeah, if normally we counsel, we do the couple counseling, but if the male is not available, then it's always ask them if they are ready for any contraceptive, then it's fine. If she's not ready, or if she's having some hitch in accepting any contraceptive, then we always ask them to come with your partner. And most of the time this couple counseling is very successful, and sometimes husband encourages their wives to opt for some contraceptive.
So that is very true, and we will discuss this
I would
mirror
like to
slide.
add one more thing, that
Yeah.
we have to make aware our patients also that after MTP, after 12 or 14 days, the ovulation starts, and post delivery, most of the time after 21 days, that ovulation starts. Sometimes they say कि अरे डॉक्टर साहब ठीक है हम बाद में समझ लेंगे. Then we have to make this very clear to them कि you may be caught if you are not aware of this reality.
Ma'am, you are muted. Dharti
Dr.
ma'am,
Bharti, unmute yourself.
ma'am, you are.
So I think that male participation is very important, and female family involvement is also very important, and that all options for the contraception should be counseled to the woman that she can use it. So till what age we have already discussed that in the postpartum, in the woman over 40 is a very detailed. Dr. Sarita has told about everything. Correct. Implants, of course, it is a new thing. Dr. Deepali, is it available at your college or in the
No,
government
no.
sector? I know that it is not
We
available.
had a training, but after that it has been withdrawn from the government sector. It's not available.
College,
It's
It
available in
is
the
not.
market, but in the colleges it
Yeah,
has been
but not college.
withdrawn.
But I was a part of this implant on in the
Yeah.
HRRC and I have inserted in the 200 women. So what I feel
Long
that of
back.
course it
Yeah.
is a good if some women, yeah, in
But it was
HRRC
not
in
planned
around.
studies. Yeah, yeah.
Yeah, not plant one जो लगा था तो
Yeah.
उसमें but I always found when I have compared from the IUCD or implant because it is not in the government setup and it is not going to be available free of cost soon. But I know that it is available on the cost only. So in our scenarios for the large population, IUCD is very good. But if someone wants implant on, they don't want to introduce in the IUCD, then they can use it. But IUCD is comparable to any long active reversible contraception, what I know. So now
it's a
because time
government.
is on, yeah. And I just want to tell that any high risk pregnancies, any our doctors, they can get it by MEC wheel very beautifully. Like if you want to patient having tuberculosis with what contraception, you can see that very beautifully written on all MEC that when you should give combined pill, when OCP, when injection. So you can do, and in fact, IUCD is not contraindicated in any case except in molar pregnancy. It can be given in all broadly IUCD if you don't think that what I should give, you can give it. And in the same way, I am just telling you, like if you want to see in the GDM what you have to give, then it is very beautifully written what you should give in the cases in the MEC wheel. So this was all about the contraception panel that how we have to increase effective use. And in fact, this is the chart which I have made. And what I have decided that in our country, LAM, PPIUCD, LAM and PPIUCD, two things, they are very effective, affordable and acceptable. That can change the scenario. Because LAM, if we will tell to every woman, definitely with that we
follows.
need the other contraception, but that is good. And second, 98 to 9% effective with the perfect use. And then PPIUCD. This is the thing that they can revolutionize our country, because in the PPIUCD, once after delivery it is inserted, then women having this and we are not need to again call her, and that is most of the time missed. And of course, the other contraception like emergency injectable contraception, and nowadays the Antara, Chaya, all things are available in the family planning program, so that can be utilized. So I think in the next few years we will have increased acceptance of contraception, um, increase acceptance of contraception, more than like saying that it is a 3.4%, IUCDs or OCPs only 4%. I think it should be 20%, 30%. Actually needed to more than 60%. But
Hope
हम उसको
so.
और बढ़ाएंगे. So this is, thank you very much
एक
about.
चीज, सॉरी डॉक्टर भारती, मैं इंटरप्ट कर रही हूँ. एक चीज और मैं कहना चाह रही थी कि वी नीड अ मल्टी डिसिप्लिनरी अप्रोच ऑल्सो. लाइक कई बार ऐसा होता है ना कि एटीटी चल रही है एंड दे कम विद प्रेगनेंसी, या सीए तो नहीं, कोलिसिस्टेक्टमी हुई, या किसी भी, इवन विद कैंसर पेशेंट्स दे कम विद pregnancy for MTP. So I think these doctors like physicians, surgeons, they should also at least वो ना भी advise करें, at least they should refer them to us कि भाई you are on this treatment and go and take some contraceptive for that. Likewise, I'll also like to include that pediatricians, बच्चे को लेके माँ जाती ही जाती है, तो they should also communicate them कि like अभी your baby is small, 2-3 साल तक नहीं होना चाहिए दूसरा बच्चा, go and meet your gynecologist for contraceptives. I think this will also increase the awareness as well as the number of the persons to choose the right contraceptive for them.
Yeah, so basically the at present, because 25 years I am practicing in OBGY, but still we are having so much low incidence and prevalence of घर क्या रहे
This
हैं,
is
हमें तो
what I
यही
wanted
लग रहा है.
to
तो
on
उसका
every
रीजन ये है कि एक तो पॉपुलेशन आपने देखा कि ज्यादा है, तो यूपी में अभी बुरे पुअर स्टैटिस्टिक्स एंड रीजन बीइंग कि पॉपुलेशन इज हाई एंड वी आर नॉट एबल टू डू. But I think it is not satisfactory. We should do something. So I only can then only OBGY small group of doctors, they cannot cover all population. Male
cover all.
participation, and that I always believe that all have done MBBS, all have done internship, any specialty person. So it's something should be happen that in every department, the counseling of the contraception should be there by the counselor. It's not something that cannot be happen. So it should be done when it would be available. Then of course maximum population would be covered. And before jobs, or before government job, or after your graduations, and something should be happen that after
Policies
90
should
years
be.
you have, yeah, or before getting driving license, you should have to fill this form. So one will be even I tell you कि अभी भी मेरे यहाँ जो रोज पेशेंट्स आते हैं, those who are never taken antenatal checkup and they are coming in the 9 month with some high risk pregnancy, abruptio, ये वो, तो मैं उनको बोलती हूँ आपने अभी तक दिखाया क्यों नहीं? पढ़े लिखे होते हैं, बड़ा स्मार्टफोन है, ठीक ठाक दिख रहे हैं. वो बोलते हैं हमें तो पता ही नहीं था दिखाना है, बहुत भोलेपन से
Yeah,
कहते हैं, तो उनको
वही
पता ही नहीं
awareness.
होता है. तो लाइक मुझे लगता है कि अगर ग्रेजुएशन के बाद समथिंग इज हैपनिंग दैट, तो दे वुड बी सेंसिटाइज कि हर प्रेगनेंसी में एज दे आर गेटिंग प्रेग्नेंट दे हैव टू कम टू द हॉस्पिटल, as in the way that they have to take contraception choice, and before marriages they should know about the contraception so they can plan their pregnancy. And of course then preconception counseling part would also be covered, so we will have good. So I think
Like this.
thank you very much for all present. Shikha, last one line comment.
And
Before message, thank you for because we all are very much busy, but we all spare time. So that is thank you for everyone. Yeah.
Thank you. Thank you, Bharti ji, for an excellent webinar. And
Yeah,
a
very
one-line
good.
message I would like to give, that contraception should not be the choice, and it should be a government policy. Only then Indians will start accepting it. That is the truth.
So there should
Yes.
be
दीपाली जी,
instead of,
आपका क्या मैसेज है?
मेरा तो यही है कि we should go for a multidisciplinary approach, as well as even paramedicals and the fourth class should also be make sensitized to counsel the patient, क्योंकि सबसे ज़्यादा वहाँ staff nurses ward में जब रहते हैं, staff nurses के contact में ही रहते हैं, या 4th class employees भी आसपास रहते हैं, तो I think everybody should be encouraged to counsel whosoever they meet.
Anita, Dr. Anita, you are here.
मैम मेरा मैसेज तो ये है कि काउंसलिंग शुड बी नॉन जजमेंटल एंड हस्बैंड शुड बी इन्वॉल्व एंड वी शुड ब्रेक द मिथ अबाउट द कॉन्ट्रासेप्शन.
डॉक्टर नलिनी आपका, डॉक्टर विद्या आपका.
When we give them option, all the options, we should solve their query, because there are lots of myths about this side effects of the contraception, especially copper T. So we should, and community involvement is also very important. Cultural beliefs, we have to address them.
Yes. And anyone, and Dr. Vidya, you are here if you can hear me. So I think individual efforts matter a lot about I feel. तो जो मेरे को लगता है कि मैं अपने लेवल पे कम कर सकती हूँ. मेरे यहाँ मेरे बहुत सारे रेजिडेंट्स होंगे एंड दे नोज दैट हाउ आई मच एम्फेसाइज कि अगर हमारे यहाँ कोई भी लैक्टेशन पीरियड में हमारी बुक पेशेंट कंसीव होके आती है तो कितना हम लोग वी टॉक दी व्हाई वी हैव नॉट काउंसल्ड. अब बहुत अलग से काउंसलिंग टीम ही बनी हुई है. हमने हर यूनिट की एक टीम ही बना दी है जो कि सिर्फ इस पर्टिकुलर काम के लिए, सो दैट वी कैन डू. एंड इवन हमारे यहाँ 3rd और 5th डे फाइल में कि क्या काउंसलिंग किया, क्या एक्सेप्ट किया, यू रोट डाउन सो दैट वी कैन फाइंड आउट कि एक्चुअली इट इज हैपनिंग और नॉट. So I do that. I think that whatever we can do best and we can sensitize as many as possible, then definitely it will. And we are as obstetrician gynecologists are, so of course it's the first line.
It's our
thing.
responsibility also.
Yeah. So we do, and
cannot
you are
deny that.
fully dedicated. Dr. Deepali, Dr. Anita, you are dedicated for these things. So we always learn from you that what we should do. So thank you very much. Vidya Dobi, madam, you are here. So please,
Yes.
yes. So you say your comment, because what the take-home message, what we should do to improve acceptance of contraception? Two, three lines.
It is a very great discussion, and usually we had earlier that family welfare clinics. Now also that postpartum clinic, as Dr. Deepali is working with. So everybody should be motivated, and actually this lactational during lactation and all, no, the people, they think that they will not conceive. That is the main primary, means most of the women, they don't accept because of this, that they feel that this oral contraceptives and all that will come into the that will reduce the breast milk secretion and all those. I think those taboos are there, their misbeliefs are there, that should be cleared. And as you have made, every unit has got, I must appreciate that you have made that efforts. Everybody has to do that efforts to make them aware. So, and we have that role plays and all, no, AdCom modules and these modules and that modules. Instead of that, we must say that these are going to real play, real, that is real role play between the, in the postpartum unit we have. Whenever we discharge the patient from the labor ward, definitely it has got impact. And
Thank
it
you
is
very
usually
much.
the family's decision, and usually husband comes in the way, means especially the PPIUCD insertion, that, and this all these things are the decisions of the family, and you should make that woman empowered, that it is your decision and you have to take the decision, that is, and your health is more important, that
Thank you.
that
Thank
is,
you, Dr. Vidya. So like this
yes.
is the, again, the chart is on my my poster that is available on a screen. You can take pictures, or I can send you, all of you,
You
those who
can
want.
circulate, you can send those who are participating. These are very good pictures and the posters what Bharti has released in her tenure, especially about the MTP Act, consent book. They are really informative. Her books are very
Very hard
informative.
work. Yeah.
Yeah.
She has
So
compiled
I
it
just
very
want
nicely.
to conclude. I just want to conclude this whole session on the ICOG, on the pregnancy by choice, not by chance, and with display of these posters, that two important methods, LAM and PPICT, that should be promoted at large level. And by this information, and I will share this PDF to all of you. Those you want, you can stick on your places, clinics, and so I think that will fulfill our purpose, which is cost effective, it is easily available. That's only information to the women should be spread. So thank you very much, all of you. and all audiences is still around more than 50 audiences are there. And I hope that all of you, those who have filled this link, they will get the e-certificate. And thank you very much to
Can
everyone.
you please
Thank you.
share the link again? That I missed
मैं आ
that.
रही हूँ, एक लेक्चर खत्म हो रहा है, मैं आ रही हूँ, एक मिनट
लिंक है इसमें अभी रखा है, चैट बॉक्स में है ये।
चैट बॉक्स में
आप
है,
अभी या
देखती हूँ।
in chat box you will get one link.
Yeah,
Okay,
yeah,
I
got it.
share
Yeah,
it.
yeah.
Yeah.
मिल गया।
Didn't receive. I can't see.
But it's not. Yeah, I've seen this. First, you have
Where it
to
is?
fill this.
There, Dr. Bharti.
I will share in the group also. उससे भी आप आराम से कर सकते हैं. I share in the 20th November.
Hello.
Yes.
Good evening, Dr.
Questions are quite easy. Questions are easy. I think they can attempt, and you can put it in the group also. Thank you very much.
Okay, bye. Should we stop? Should we leave? Okay.
Yes, ma'am.
Yeah.
Bye. Thank you.
What about
Bye.
answers?
Thank you.
You have to share the answers also. Yeah, thank you.